All right, well, I'll say it again. Anyway, welcome this morning to everybody who's here in person, and for those online. I get to kick off the learning today, really talking about the basics of dementia for the family caregiver training. And I think we'll cover some important topics today that hopefully then launches you guys on to really what your role is as family caregivers, people supporting others that have memory and thinking problems. So probably the biggest question that we get when we speak in general, and it doesn't matter, if I'm talking with other health professionals and doctors, there's this big confusion over dementia versus Alzheimer's disease or frontotemporal or Lewy body disease, and that's really important. I get many patients that come into clinic and they're delighted with themselves. They say, my doctor says I don't have Alzheimer's disease, I just have dementia. And I just smile a little bit and say, well, that's fantastic. But dementia really just means having trouble with your memory and thinking. It may not be memory, it may be other aspects of thinking, but having trouble with your thinking that is starting to impact your daily life and function. And that's important. And so we really don't diagnose dementia. You diagnose dementia. You say, either I or a loved one are having memory problems that we need to take a look at. And that really is that diagnosis in general. So what do we do medically is our job really is to find out why that is. So there are a few aspects to dementia that we need to understand. The first is that age is the number one risk factor. So we read a lot about risk factors, but age is the number one risk factor. So you can see here that the number of people with dementia doubles every 5 years after the age of 65. So it leads to this exponential curve. And many studies suggest that by the time you reach your mid-80s, it's 1 out of every 2 people. And I lecture the medical students, and I say, if you have a holiday dinner with grandma and grandpa, and they're both in their 80s, take a look. Chances are one of them, by odds, is going to have memory problems, whether those are recognized or not. So this helps us with our index of suspicion for whether or not we need to be worried about a memory problem, although dementia and even Alzheimer's can occur in much, much younger people. So we had somebody in last week, 34 years old, with a genetic form of Alzheimer's disease, already struggling and having difficulties. But that's kind of rare. So we do need to understand why there's a barrier to diagnosis. First off, the patient is typically unaware of their symptoms. So you have to think, if all of a sudden you develop memory problems, the last memory you have is of having a good memory. So everybody thinks that our patients with dementia or Alzheimer's are denying their problem, but they can't see it. It's not denial. They can't see it. We have a term for that called anosognosia. So frequently, folks may not necessarily seek out help or evaluation themselves. And then there's a lot of thought out there that the evaluation, maybe this is just going to take too much time. And for doctors, well, by golly, sometimes your primary care doc that only has 10, 15 minutes to spend with you, if you open that can of worms, I think my loved one has a memory problem. They're thinking, oh my God, there goes my day. I'm going to be behind schedule for every patient here. So important. There's also a widespread belief that memory loss and cognitive decline are just part of normal aging. There are some changes as we age. Our speed of thought tends to decrease. On the other hand, our accuracy of our thoughts actually increases. It's kind of a counterbalance, and I think this explains a few things in the human condition that we know, is that when you're young, adolescent or young adult, your brain is working at warp speed, but it's coming up with lousy solutions, so they get themselves in trouble all the time. As we get older, we may need a little more time. Oh, that name's not popping into my head, but then eventually it comes. But when we finally settle on something, we're always right. That's the privilege of aging. Anyway, so memory loss, if that name doesn't come to you ever, that's a problem. If it comes a little bit slower, that's okay, as long as it comes. And there's widespread belief by many that why bother being evaluated, why bother with a diagnosis? There's nothing anybody can do about it anyway. And so we're going to talk about all those issues today. But very, very important to understand the disease course. So some of you may have loved ones that are at different stages of disease. And so on the y-axis is a simple memory test from 0 to 30 called the MMSE, and years from diagnosis. And what we can see is that folks start to develop some memory symptoms, early memory symptoms they may actually recognize. I'm not doing so good, but then that recognition is lost over time. There's this delay, and that delay to diagnosis is over 3 years. So people typically, and this is not uncommon in clinic, for us to come in and say, when did the memory problems start? And people will be like, well, it's been 2 years, it's 5 years now, kind of thing. So hastening this, is really important by opening our eyes anyway. As the memory and thinking problem gets worse, there's a loss of functional independence. I can't use my cell phone anymore, can't drive to unfamiliar places. Eventually that can get worse. We can start to see behavioral problems, and eventually somebody will need assistance with their daily cares, need assistance with taking a shower, need assistance sometimes dressing themselves. And so it says nursing home placement here, but not everybody goes to a nursing home. Thank God. Many do, and for many it is an important consideration for the care of a loved one, because nursing facilities, memory care units do have an entire staff. And you can be the world's best caregiver, but if you're an army of one, let me tell you, you're not going to be as effective as a team. So if you are going to care for somebody at home in the later stages of disease where they need 24-hour assist, you really need to not think, I'm going to do this all myself, or you're going to kill yourself, and then you're going to be of no use to anybody. You're not going to be able to help anybody. You've got to set up a team, or you've got to find a team, and frequently that can be a skilled facility or memory unit. So, now, as a professor here, I'm kind of fond of the absent-minded professor. They're cute. So having a memory problem is not really the main issue, for me anyway. The issue for me is that functional loss. And so here we're looking at it a little different. On the x-axis is that MMSE score 0 to 30, and the bars show that as people progress, what function they might lose. So ability to keep appointments, use the telephone initially. Then we might start having trouble with home appliances. We see that all the time, and frequently you'll notice that when you get a new appliance in the home. Oh, there's this new fancy microwave. This thing does everything, It'll make you a cappuccino and popcorn simultaneously. And it's moved into the house, and somebody just can't figure that out. This is a new thing. But dressing, eventually even walking and eating, and we'll talk about the very end stages of dementia. Very, very important. So this is what I really care about, keeping people functionally doing well. And so this is a big problem. So this is data is a little outdated. Right now there are 6.9 million people in the United States with dementia. Those are the latest facts and figures. Here I have listed just 5.8. But the same basic thing holds true. If we look at the population of the United States in the green circle, we see that about 13% are over the age of 65. And if we blow up that little piece of yellow pie, we can see that 13% of that, 1 out of every 6 people over the age of 65, actually has dementia. They're struggling with their daily functions. Oops. But we do know that unless you have a major stroke,
Somebody's phone.
Somebody needs to mute if they're online.
No, it's not on.
No, it's
All right.
It's okay.
All right, very good. So, so unless you have a major stroke, you don't go from normal to dementia overnight. There's an intervening stage that we call mild cognitive impairment, where we can notice memory or thinking problems, but people are compensating. Lots of sticky notes, lots of calendars, and that's okay. That's a warning stage. It's a warning stage that we are likely to head into further problems in the future unless we do something about it. So when we look at MCI and add that to dementia, now we're talking about doubling that number. So currently that will put us at about 14 million people. 1 out of every 3 people over the age of 65 has one of these conditions. So that is common. So again, sometimes, it's easy to think, why me? Or, oh my God, I can't believe, that I'm alone. There's nobody else in the world with this. It's 1 out of 3. That's huge. You're not alone, and nobody's picking on you. This is a part of the human condition right now. So there are different causes of dementia, and you're going to bring your loved one to a doctor to actually figure this out, right? Is this a neurodegenerative condition? And I have the big 4 up there. We'll talk about them: Alzheimer's, frontotemporal dementia, dementia with Lewy bodies, and vascular dementia, but several other rarer forms of disease. Primarily, the job of the doctor, first off, is to look for what's on the right-hand side of the screen. What are the medical causes of dementia? Frequently, we'll see people that are drinking too much alcohol and suffering from vitamin deficiencies, or are on inappropriate medications that we can fix, have thyroid problems, or other disorders. So we're always looking for these. Why? Because we can fix these problems. So if you have a loved one that's not had a medical workup, chances are these things haven't been looked at, because most primary care docs, unless there's a reason for them to look, are not going to look. It's not part of your annual physical. So really, really important to have that workup. And then there are screening questions. And so this is something called the AD8. You guys can use this if you want to. It was developed by Jim Galvin when he was at Washington University years ago. It's a series of 8 questions. And if somebody answers yes to 2 of these questions, they have a 92% chance that they have MCI or dementia. So just 2 of these questions, though. You guys can think about this. Do they have problems with judgment, problems making decisions, bad financial decisions, problems with thinking? And remember, that's really talking about changes from the past. So I'm, I think, a good doctor and a good scientist, but I'm horrible with money. And so I'm not allowed to make financial decisions in my household. Now, that's not a change for me. I've always been horrible at finance. We're really looking for changes. Less interest in hobbies and activities. This is a big early warning sign. We think, well, they're just old and they just don't have time for that. But, people giving up their interest in hobbies and activities is a real problem. Repeating themselves over and over again is a problem. Trouble learning how to use a tool, appliance, or gadget, forgetting the correct month or year. I never really mind when somebody comes into clinic, today's Tuesday, and I ask them what day of the week is it, and they're like, I don't know, I'm not working anymore. It's, towards the beginning of the week, but more like the middle, Tuesday or Wednesday, I don't know, I'm okay with that. I don't want to know the day of the week when I retire. But when they come in, like my patient yesterday, and I ask them, what month is it? And they tell me it's July, and there's snow outside, although it's gone today, I think. Then I think there's a real problem there. Trouble handling complicated financial affairs, balancing checkbook. Again, for me, it's lifelong, so it wouldn't really count. Trouble remembering appointments, daily problems with memory and thinking. So think to yourself, really, answering yes to 2 of those, pretty low bar, but we need to recognize this. Now, one of the things that your loved one should get in an evaluation as well is for people to look at the other things that can occur alongside of a memory or thinking problem. So depression and anxiety, really important. They may need to be treated. Behavioral problems, personality change, inappropriate behaviors, these may need to be addressed. Hallucinations, delusions, paranoia, very, very common. We frequently can see in Alzheimer's disease, people develop what we call a Capgras syndrome. I want to go home. And you're like, well, you are home. No, I want to go home. And that can be a problem to deal with. Sleep difficulties, really, really important. I don't know why, but our Alzheimer patients like to flip their circadian rhythm. They'll sleep in front of the TV all day long, and then they're up rummaging around the house in the middle of the night. That's when they wander off. That's when we're calling our silver alerts and the like, and that's problematic for both the person as well as the family members that are caring for them, not being able to get a full night's sleep. And then there can be some physical and motor symptoms. Parkinsonism runs hand in hand with Alzheimer's disease in many cases, not all though, and strokes and the like. So there's more than just memory involved here. Now, at the doctor's office, they likely they should. If they don't, you need a different doctor, but they should test memory and thinking. And we use these cute little tests. It's got little animal pictures on it. I don't know why, but in Kentucky, everybody calls this a hippo. What's this animal?
A rhinoceros.
Thank God you guys all passed the test this morning. I don't know why everybody thinks that's a rhino. I haven't figured that out. And this one, always stumps me. Is it a dromedary or a camel? Which one has more than one hump? Does anybody know?
No clue.
No, I don't know either. I don't know either. Anyway, and what it does is this type of testing is looking at different areas. So yes, there's memory, delayed recall and learning for memory, but there's other, can you name these? What's your language like? Other tests of language, repeat these phrases, name words starting with the letter F. Attention, can they focus? Visuospatial, can they draw a cube and a clock? So we're testing a variety of different aspects of the brain because sometimes the problem is not memory. And when it is memory, in Alzheimer's, it's typically short-term memory. So I have many folks that come in and say, well, their memory is great. They can recount the day we got married with better detail than I have. They can pull up all their friends or co-football players on the high school team and list them out. And the long-term memories actually get stronger as one develops a short-term memory problem. So that's kind of paradoxical, but we're looking at what you have for breakfast this morning, right? So if you go home later today and you don't remember you had a bagel here, that will be a problem. That will be a problem for us. So, and then, of course, there is a workup. And the workup includes brain imaging. Frequently, we try to get an MRI, or sometimes we can't if people have metal in their body, and we have to get a CT scan. But this can be very revealing for us, and all insurance, including Medicare, pays for this. If the question is there a memory problem, this is covered. So we can look at a healthy control with a big, full, plump, juicy brain, or an Alzheimer brain, and you can see that it's shrinking here. There's a lot of more black space where there's spinal fluid rather than brain tissue. And these are the memory areas. Specifically, we can look at those and say, oh, this looks like Alzheimer's. Sometimes we find tumors. I have a young patient in the hospital right now who was developing slowly progressive memory problems over the last 3 years. and he came in to see me, and I sent him for a picture of his brain, and by golly, he has a big old brain tumor, a meningioma. It's kind of a benign tumor, but it was growing and squishing his frontal lobes to the point where he needed emergent surgery. And I saw that and said, you need to go into the hospital and get this thing popped out of your head. Now I have high hopes that he's going to do great afterwards. Sometimes people can build up too much spinal fluid, what we call NPH. Sometimes they can have this white stuff. This is an old stroke. These are all little mini strokes, lacunar strokes, vascular dementia. And then some of the forms of frontotemporal dementia will have very specific patterns where you see the black increase showing different areas affected in different people. And so this helps the doc, number one, to make sure we don't have these other fixable problems, right? But also the pattern of how the brain is shrinking can be very, very telling for an expert. So this is just shows again the memory areas. This is looking at the brain in a little different way, kind of like you were sliced like a stick of pepperoni. And what you see in red are the memory areas. So we can see a 25-year-old has big, plump memory areas in the brain. And as we age at 75, you can see that those memory areas have shrunken a little bit, but there's still lots of good nerve cells in there, and so they're normal in their memory and thinking. But if you start developing memory problems caused by Alzheimer's, you'll see these areas shrink even more. And so this can be very telling for us. We sometimes will ask folks to go for additional testing, and you should be prepared for that. It's not needed in everybody. It's needed in only a small number, but sometimes we do. So this is what we call FDG PET. It's sugar that it has a radioactive label on it, and if we give it to somebody who's normal, the brain eats a lot of sugar. As a matter of fact, the brain, even though your brain only weighs about 2.5 pounds, it eats 25% of the glucose in your bloodstream. It's constantly, it's more active than your heart, which is sitting there beating once every second or so. That's pretty darn amazing. So we look at this, and this is a healthy brain. It's using lots of sugar. This is what an Alzheimer brain looks like. The nerve cells are sick. They can't use the sugar. They can't power up. Nowadays as well, we use sometimes molecular PET imaging. This is PET imaging that was developed that can actually look at the plaques in the brain. So we used to say you can't diagnose Alzheimer's until somebody dies and comes to autopsy. That's not true. That hasn't been true for over 20 years, almost 30 years now. We have this ability. And so here's an Alzheimer patient. Again, this is a radioactive dye. The radioactivity is benign, only lasts a few seconds or minutes, doesn't cause any real problems. It's injected into a vein, and it sticks to the plaques in the brain. We've also noticed over time that we can pick this up in HC, that's a human control. Some people that are normal, 1 out of 3 over the age of 65, will already have low levels of amyloid building up in the brain, and we're trying to work on that as well. But we need this. Sometimes we're going to talk about the new therapies for Alzheimer's as we get into this, and sometimes we do need this testing, or spinal fluid testing. So spinal fluid, since 1998, has been able to measure the amount of amyloid plaques and tangles in the brain. And this is my back donating my spinal fluid for research while my resident over here was sweating bullets. Anyway, that video is online. Sometimes people cringe about that. We do them here. It's like a blood draw for most people. Now, I do want to switch because besides memory loss, there are a variety of other things that you can see, and these need to be dealt with. So there's that lack of initiative. I don't want to do my favorite things anymore. There can be mood swings, depression, agitation, anger, resistance to care. Don't help me, I'm fine. Wandering, pacing, I want to go home. We talked about that. Shadowing, does everybody know what shadowing is? So your little kids do that, they go through that period of time where they want to hang onto mom's leg and don't want to leave her side. Our folks have this as well, and you have to think, why would they have that behavior? Well, if you have a short-term memory problem and your loved one goes to the bathroom for 10 seconds, you don't know. Have they been gone for hours? Did they abandon me? Did they drive away? Are they ever coming back? You don't know. So having that person always in front of you can be very reassuring. There can be hallucinations, paranoia, changes in sleep patterns, rummaging and hoarding. As a matter of fact, two of my cutest patients ever, a husband and wife, simultaneously developed dementia. She had Alzheimer's disease and he had vascular dementia. And she loved teddy bears and was a teddy bear collector. And as she was starting to develop memory problems, she hopped online and she was on eBay buying teddy bears up the wazoo. And the husband got a little perturbed, and he liked to add a collection of Matchbox cars from his childhood. So he said, well, I'm going to start ordering Matchbox cars. The family came over for Thanksgiving, went out into the garage for something, and when they opened the door, it was stacked full of boxes of teddy bears and Matchbox cars. They spent their entire retirement hundreds of thousands of dollars on teddy bears and cars. Took the family about 5 to 6 years to sell them all back on eBay. I think he made a profit though, overall, but we can see this. Loud verbal noises, yelling, abusive, combative behaviors. So these psychiatric symptoms are the most testing. So when we look at what is going to increase caregiver stress and burden, it's these problems. Not when they ask you the same question over and over again, it's annoying. And sometimes you might lose your cool. It's okay, we're all human. But these are the problems. And we can see the red line here is when a diagnosis is made, we can see that 3 years before a person's diagnosed, they're starting to withdraw. I no longer want to go to church. I don't want to go to my book club anymore. 2 years before a diagnosis is made, over half of people have depression that have never been depressed before in their life. And depression, believe it or not, is really not a part of normal aging. People, we always say aging is not for sissies. There's a lot of aches and pains and other things, but most people as they age are actually resistant to depression. But when we see that depression coming out, it's often a harbinger. And if you look within 1 year of a diagnosis, 80% of people can start experiencing agitation. This is problematic. Now many people say, well, they're just behaving poorly. This is really not under the control of the person with memory and thinking problems. It's because there's involvement of all of the different degenerative dementias with what we call the limbic system. This is the ancient emotional area of the brain. And it turns out, that the hippocampus, the memory area in green, is part of that emotional circuitry. And so that makes sense. I always say, Mr. Spock or Dr. Spock on Star Trek, ruined it. They made us think that memory and intelligence was cold and logical and without emotion. There's nothing further from the truth. As a matter of fact, memory and intelligence is emotionally laden. It has to be, so that we understand what's important and what's not. So any person who is having trouble with their memory, I guarantee you they're having trouble with their emotional control and regulation. It's kind of like stealing their Clint Eastwood from them. Slowly but slowly. Things that never would have ruffled their feathers before now can ruffle their feathers. So, again, this is a big problem. We call it BPSD, Behavioral and Psychiatric Symptoms of Dementia. These accounts for 30% of the cost associated with dementia, associated with the likelihood that you may all become depressed. strongly associated with the need for nursing home placement. They undermine your ability to provide care and are just a big problem. So when we see these, we have to think. And so this is the first stage before we just bring somebody to a doctor saying, my loved one is, freaking out. You really need to stop and think, why are they doing this? What is there a particular time of day? Is there a particular event that triggers this? Frequently, the behavioral outbursts may be an expression: I'm thirsty, I'm hungry, I'm in pain, I'm distressed, I feel like I'm abandoned, I'm afraid. And so if we think about that and try to put ourselves in our loved one's shoes, why? Why are they so anxious? Why are they so fearful? And then we can understand we don't want them to think that way. If it is thirst, hunger, or pain, well, some acetaminophen, a big glass of lemonade, and a sandwich might just do the trick, and that would be better than a doctor throwing medicine at them anyway. We also think about environmental factors, excessive stimulation. Sometimes we need it quieter. We see this at the holidays all the time. The whole family's coming over. We got 40 people in the house. Two of the brothers are fighting in one corner. The sisters are trying to outdo each other on the other side of the room. So sometimes thinking about that, limiting the size of groups. Everyone knows when something disrupts the daily routine and structure, this is problematic. So vacations sometimes, they've always loved going to Florida. Now we have a major freak out because we're out of our routine. So if you're going to travel with your loved one, you should be thinking about, all right, well, we're going to go to Florida, but how can we adopt the same routine so this is as least disruptive? Inadequate lighting is a big one. Confusing surroundings. When you have a loved one who develops dementia, this is not the time to rearrange the furniture in the living room. I leave everything the way that it was. Really important. Just simply moving a few chairs to put up a huge Christmas tree, that can be incredibly disorienting and confusing. Maybe getting a little one that sits on the coffee table. Excessive demands, the distressing behavior of others. I can't tell you how often I had somebody come into clinic and I walk into the little exam room and there's 12 people in there and it's like holiday at my house with some arguing, you're not doing a good job caring for mom, Yes, I am. And I had to tell them, everybody out, except for the patient and one selected family member. Get out, so that we can actually talk and get through things. So again, if you look at all these things and we're still having trouble, then you do want to raise this with the doctor, right? And the doctor should take a little history, what's going on here. You want to tell the doctor about, I increased the lighting. We're trying to stick to a routine, but this is still happening. The doctor may look for medical problems. A simple urinary tract infection is our biggest culprit. Upper respiratory infection, a mild illness. Or it may be that they took an extra, Tylenol PM. Before they went to bed at night. They're not sleeping well. So your doctor should look for medical problems, drug effects as well. There are a lot of over-the-counter and prescription medicines that can impair memory and thinking, and this is the doctor's job to look at that. You can also ask your pharmacist, would you take a look at my loved one? Tell them as well about the over-the-counter medicines that your loved one's on, because simple things, like the Pepsid that you can buy over-the-counter for stomach upset, can impair the memory and thinking. Benadryl over-the-counter sleep aids. All the over-the-counters all have Benadryl in them, and that's an antihistamine that can cause memory problems in our folks. Some antidepressants, some seizure medications, steroids for rheumatoid arthritis. These all can be problems. So What are we going to do to manage these things? Well, the first thing we're going to do is we're going to look at our environment. Let's get a routine. Let's make sure it's secure and safe. Let's maintain those routines. Let's have some activities to engage. Attend any medical, physical conditions. We certainly need to support the caregiver. If your loved one, the more behaviors that your loved one is having, and not everybody does, but the more behaviors that they're having, the more support you're going to need. So you have to think about that. Adequate nutrition and sleep. And then always we treat the dementia first. So a few other things I won't get into. We hopefully you'll learn these today. There are ways to distract and redirect the patient towards more positive activity. Adjust the environment, structure consistency, avoid that overstimulation, and again, planned activities are important. You want to communicate clearly, speak clearly and at a steady pace. Keep your language simple and engage eye contact. This is really, really important. Our folks with memory problems are emotional mirrors. If you are upset, they will become upset. If you are chill, they will be chill. They will reflect this. Very, very important. I take a medical student and a resident into the room with me to see a patient. In 10 seconds, I know whether or not they should work with the elderly with memory problems. And I tell them right out, you don't got it. Don't go into this field. Go somewhere else. You make me nervous. Right? Really important. Address by name. Reaffirm who you are. I'm big on touch. Every now and then a patient thinks I'm getting fresh with them, but simply holding somebody's hand when you're talking and communicating with them is very, very comforting as well. So I'm just going to recap on diagnosis. This is when you're going to reach out to a doctor. You're going to see a memory complaint or behavioral change or something's changing here, and you're going to bring them in to see the doctor. They're going to do a bedside evaluation, so in the outpatient setting of some memory testing. They can order more extensive memory testing if they need it, but usually the bedside evaluation is pretty good. We're going to get a medical workup, imaging, and some lab testing, and this is very proscripted, but again, if your loved one has not had a picture of their brain and or laboratory testing, they need that. Absolutely. Then we can establish a diagnosis of dementia and start to look at what type of dementia. In some cases, we may need to use spinal fluid or one of the PET scans to define that diagnosis. But at the end of the day, we come up with, all right, here's what we think is going on. And frequently it is Alzheimer's disease. And so this is an Alzheimer brain, shrinkage of the brain from a loss of nerve cells. And Alzheimer's himself in 1906 published on this. This is a silver stain that lights up an amyloid plaque. This is outside of nerve cells. So the nerve cells are little tiny things like up here. And so these are outside. And tangles, neurofibrillary tangles, this is inside a nerve cell. Of course, this is much blown up over this one. But this is Alzheimer's disease. So we're going to watch a brief video on Alzheimer's disease, if this works.
Alzheimer's disease was described for the first time in 1907 by the German psychiatrist Alois Alzheimer. In performing a histopathologic study of the brain of his patient Auguste, suffering from dementia, he brought to light the presence of two types of lesions in the brain, senile plaques and neurofibrillary tangles. He reached the conclusion of a distinct disease of the cerebral cortex. 100 years later, thanks to current scientific techniques, research has made a great leap in the understanding of the disease. We know that the brain is made up of neurons and that these are interconnected to form a vast network. These connections, known as synapses, enable the transmission of information from one neuron to another. In Alzheimer's disease, 10 to 15 years before the appearance of the symptoms, two main lesions form in the brain: senile plaques, composed of amyloid-bedded protein, and neurofibrillary tangles, composed of tau protein. How is the senile plaque formed? On the surface of the neuron is a large protein called APP. Normally, APP is sectioned by enzymes on the surface of the neuron, and it frees a protein called amyloid beta. The amyloid beta protein is then cleared in the body. In the case of Alzheimer's disease, there is an imbalance. The amyloid beta protein is no longer regulated and is found in too great a quantity. The proteins assemble to form indissoluble fibrils and create senile plaques. How are neurofibrillary tangles formed? When a neuron communicates with another, a signal goes from the body, known as soma, to the synapse to transfer the information. The signal passes through the skeleton of the neuron, composed of microtubules. These microtubules are stabilized by normal tau protein. In Alzheimer's disease, tau protein becomes defective and detaches from the microtubules. Thus, the skeleton of the neuron dissociates as it is no longer maintained. Defective tau proteins then assemble to form filaments in the neuron. Without the skeleton, the neurons degenerate and connections between the neurons are lost. The abnormal accumulation of tau filaments in the neuron creates neurofibrillary tangles and eventually causes the death of the neuron. How do the two lesions spread throughout the brain?
So I think we'll move on from that anyway, because I have a bunch of other things and I don't want to tie you guys up all day long. But it is about these plaques and tangles. So medically, that's what we're looking at, and we'll get back to that. I'll briefly talk about genetics because we get a lot of questions on this. There is true genetic Alzheimer's disease, and you can see up here, it is extremely rare. There are only 500 families in the world. People get these mutations, they will get Alzheimer's, and it is very predictable. Typically, they come down with Alzheimer's in their 40s. By the time you reach your 60s, it is not true genetic Alzheimer's disease, but there are risk genes that are responsible for up to 50% or more of the risk for Alzheimer's, but a lot of environmental risks as well. And so the older in life someone is, the less likely genetics are playing a role. The younger their age of onset, the more likely they may have a risk gene. So this is just a description of risk gene here. I like using this. This is the chubby gene. I got this from my mom, and it makes me want to carry around a few extra pounds. Now, this is what we call a family pedigree. So great-grandpa here, the square in red, has a risk gene and develops Alzheimer's disease. His wife does not have the gene and never develops Alzheimer's. They pass that risk gene down. He has a son who gets the gene but never gets Alzheimer's. He has a daughter who gets the gene and does have Alzheimer's. His son then has a grandson who gets the gene and develops Alzheimer's. The daughter has a daughter who gets the gene but doesn't develop Alzheimer's, but then her son, the great-grandson, develops Alzheimer's and gets the gene. Now, this is not like witchcraft. It does not alternate every other generation. But it is a risk. So you can get a risk gene and never get Alzheimer's, or you can get a risk gene and get Alzheimer's disease. So very, very important. We typically don't search for genetic risk factors unless this becomes important for some of the new medicines for Alzheimer's, where we need to understand somebody's safety, and the risk genes are important for that. So I'm going to switch gears as well and just talk about what you might hear from the doctor. And it's quite frequent that people just don't have one disease. Or you may think it's Alzheimer's, but then they come in and it's really vascular dementia or Lewy body disease. So we've known for years that not everything is Alzheimer's, and many times it could be there's some Alzheimer's and some vascular disease, what we used to call hardening of the arteries, and the two are very, very common in folks together. Or it's Alzheimer's, but there's some Lewy body disease as well. Very, very common. 40 to 50% of Alzheimer cases will have abnormal Parkinson's proteins as well, whether or not they develop Parkinson's disease. So these big four are what we diagnose most commonly: Alzheimer's disease, plaques and tangles, vascular dementia, there may be strokes in the brain, Lewy body disease, different proteins, alpha-synuclein here, and forms of frontotemporal dementia with yet different proteins as well. So there are criteria for these, so clinically we can try to figure out what each person has. I won't go into that. And when we see somebody early, so if we have somebody brought to clinic very early in the disease course, we can be very, very accurate. So these are all the same: cognition in yellow, language in orange, psychiatric symptoms in red, that might be hallucinations, behavioral changes in white, and motor changes in green. An Alzheimer patient looks different from a vascular patient, who looks different from a Lewy body patient, who looks different from a frontotemporal. So clinically, we can tease these apart. As the disease begins to progress, we start seeing problems in more and more of these areas. By the time one is in the moderate stage of disease, it becomes more difficult to tell them apart. And at the end stages of disease, the brain has so much damage, no matter what the underlying cause is, that all dementia looks identical. And so we'll talk a little bit about that. The final stages, a person may lose the ability to walk and or the desire to eat or drink. And most of our patients with dementia end up passing away from being bedbound, from a lack of hydration and or nutrition, and that's common. With that being said, I've never had a dementia patient ever die of thirst or hunger. Never. Because they're not thirsty and they're not hungry. And you can't die of thirst if you're not thirsty. And you can't die of hunger if you're not hungry. This is kind of, something that, if there's a silver lining in dementia, the good Lord put it in two places. One, they don't know the problem that they're having. I think that's a blessing. I don't want them to know. I want them to think that they're fine. And the second is that naturally, the disease tells them, you no longer need to eat and drink. You need to be at peace and pass. But we can see some things that can be surprising. We can see seizures in up to 1 out of every 10 patients with the dementia. And so don't freak out if you see this. They're easily treatable. You need to call the doctor. A lot more work is going to come on hand when somebody loses their ability to control their bowel and bladder. That's a significant ramp up in doing the bed sheets every day. The cost of Depends is astronomical. We'll have to adapt our strategies as we go. So let's switch in the final point and talk about treatment. By golly. So there are always things to treat. So we're still looking for ways to cure the disease and or prevent it, all of the diseases. But in the meanwhile, we have very good medicines to help with memory and thinking, to help with behavioral issues, to help with psychiatric issues, and to help with motor issues and physical functioning. Very, very important. And so frequently for folks that come in and see me, I may ask if there are multiple here, I may say, what is the biggest problem right now? And then we'll address the biggest problem, and then we'll bring you back in a few months and tackle the next problem. And you have to repeat this regularly, because a patient with dementia that I see today that comes back in 6 months is going to be a different person in 6 months, because their brain is going to be different. It's going to have changed. And so sometimes I have to stop medicines that they no longer need. Sometimes I have to start medicines because they have new problems that have emerged. Now, the mainstay for treatment over time has been what we call cholinesterase inhibitors. This is Aricept and Nepozil, Exelon, rivastigmine, and rarely anymore do we see people on Razidine galantamine. These are all, I don't know why this is switching on me today. This is where the effect is, this acetylcholinesterase inhibition. So people will argue about some of these other properties, but they're not really issues. Now, the major side effects of these medicines can be stomach upset or diarrhea, and that's because they not only turn on the brain, but they turn on the gut. So the rivastigmine was made into a patch form. The patch, there's less likelihood of stomach side effects. They can cause vivid, disturbing dreams at night. They can potentially slow the heart rate, but we rarely, if ever, see these other sorts of problems. It's almost always stomach upset. We do have other medicines that have been developed. Memantine was approved in 2004, the cholinesterase inhibitors since 1997. This medicine works in a different way, but it works on many different components of disease. So we often combine these medicines. So here's our curve, right, of what's happening to a person untreated with Alzheimer's disease. And we can see if we put them on a cholinesterase inhibitor, we don't stop the disease, but we shift it to the right. And if we use both of these medicines, we get this curve. And so at the end of the day, they're not going to change the disease. The time course, the eventual passing of the person is going to continue. You're not going to extend that. But during the course of disease, you could be at the green line, the yellow dot, or the red dot. Now, for the same duration of disease at 4 years, this person's just starting to struggle with their cell phone and driving a car. Whereas this person is agitated, hallucinating, and having trouble getting dressed. That's a big difference. And as we see in the disease, every step of the way, for me, I would rather be on the green dotted line. I would rather my patients are on the green dotted line. This is what the data shows. So people who say these medicines don't work, yes, they're not going to stop the disease. They're going to get worse. So you can't say, well, the medicine's not working anymore, because we know with the medicine they're going to get worse, but they'd be much worse without the medicine. Sometimes people do ask and say, I don't think the medicine's working anymore, can we stop it? And then I say, all right, sure, we can stop it, but watch them. If you see them frequently when we withdraw these medicines, or if a prescription refill is not on time, we'll see them get dramatically worse. And then we know we got to get them right back on those medications. I have a general rule when it comes to those Alzheimer medications. It's what I call the smile test. If my patient still smiles when a family asks me, should we leave them on their memory medicine? I ask the family member, do they smile? Do they have periods of the day where they enjoy life? And if the answer to that is yes, I say keep the medicine on. If they say no, they're no longer responsive to the world around them, they're just laying in bed, they don't recognize me, they don't want to eat or drink, then I say, all right, if they're not smiling and we don't have quality of life, let them go. Now, there are other things that one can do. The National Academies of Science, Medicine, and Engineering, Consensus 2018, we have a recent one from last year, same sort of thing. Overall, 3 interventions: cognitive training, so stimulating the brain. Doesn't matter what you do at home, but something to stimulate their brain. Blood pressure management for those with hypertension, and increased physical activity. That can just be walking around the block once a day when the weather's nicer out. These have minimal risk of harm, and they are beneficial. Diet and social activity, also important, but there's not a lot of good data out there. So yes, the other things that you want to do are really important. Now I'm going to turn in the final few minutes to the new medications. We've been working for cures for a long time. As a matter of fact, in 1998, the first vaccine for Alzheimer's was developed. And unfortunately, it had to be stopped. It looks like it worked, but it actually killed about 6% of the people that were in the clinical studies. 94% did great, but 6%, we can't let people die from our treatment. So it was halted. And in 2005, we started playing around with, instead of trying to vaccinate people, let's give them antibodies in an infusion that we can start, we can stop, we can regulate and control. And that's been a kind of a long road up to the point where we are currently. Now in 2025, we have 2 agents with full FDA approval, and we'll take a look at those. So lecanemab is one of those drugs, and looking at removal of amyloid plaques from the brain on PET scan, we explored the dosing. We were part of these early phase 2 studies dating back to 2011, and then the phase 3 studies that clearly show that these medicines will 100% remove the amyloid plaques from the brain, but they only slow the disease by about 27 to 40%. So it's not a cure. And there can be side effects. These pictures of the brain down here show this swelling in the brain or bleeding in the brain that can occur in a small number of patients, 10% to 15% or so with this agent, although that can vary. Now we do MRIs, so people have to get MRIs when they're on these therapies so that we can monitor for this. Most of the people, even with change like this, have no symptoms. We see this on the MRI, and that tells us we're removing the amyloid too fast. Let's stop for a little while and let the brain heal. So very, very important. There are many different antibodies. The antibodies that are most effective are the ones that do the best job clearing the plaques from the brain. There have been several that have failed because they don't remove the plaques from the brain, and we know that's important. Now, sometimes people have argued, well, maybe it's not all that beneficial. The slowing of disease, it was measured at 18 months. And at 18 months, it is minimal to moderate, depending on how cup half full, cup half empty, benefit of these medicines. But the way that they work, separating these 2 lines, the benefit gets greater and greater over time. So again, it's that delay to needing full-time 24-hour care. And there's potential that these medicines will buy people an additional 4 years of quality of life. So very important. Now, these medicines are not for everybody. We typically will check spinal fluid and or an amyloid PET scan before we give someone these medicines, because we need to make sure that they really have amyloid plaques in the brain. They have to get MRIs. If they can't have an MRI, then they can't have these medicines. We have to be concerned about those on blood thinners because they could develop a bleed in the brain. on these medications, and that's very important. Now, we are seeing Medicare and others covering these costs. There can be some out-of-pocket co-pays associated with them. The company does have a patient assistance program that can help cover those co-pays. So I'll end there and just say there are many other medicines. So this is just a little wheel here. It shows all the other medicines that are currently in research studies that we are testing. And one has to figure these medicines that are currently FDA approved are just available over the last year or so for our patients. We've been giving them to people since the first anti-amyloid antibodies I gave to a person here at UK in 2007. That's a long time ago. That's 18 years ago, 2 decades. The new medicines that are in clinical trials have 20 years of technologic advancement. Our new medicines are going to be even more powerful, potentially attacking the tangles, not just the plaques and other aspects of disease. So if you have a loved one with disease and you would like to do more, you would like to see if they could be benefit from these experimental medicines, or you want to leave a legacy so our children and grandchildren enter a world or grow into a world where Alzheimer's is cured, this is a great way to get engaged. So I will end there, and I don't know if I have time for questions. It took me a full hour.
We have a few minutes if you have time.
I do have time.
Are there any questions?
So, Dr. Checa, I do have one question for you.
Yeah.
So you talked a lot about the different types of dementias and how that affects the medical treatments. From our perspective as caregivers, how much does that matter for what we're practically going to do?
Yeah,
day to day?
it matters a tremendous amount
Okay.
because it really determines that course, especially in the early, mild and moderate stages of disease. If we have somebody who has frontotemporal dementia, we know that memory's not really going to be the problem, but we should be prepared for a lot of abnormal behaviors. And sometimes that can be very simple. Some of our folks with frontotemporal dementia, because they do such weird things, we give their loved ones a little card that they can carry around that basically they can show to folks that says, my love, forgive their behaviors, they have dementia. Because sometimes you'll have somebody with frontotemporal dementia who decides that they just are fascinated with children and they don't understand interpersonal barriers. And you can imagine 70-year-old gentleman out at the school playground touching and pawing all the kids. It's benign from his perspective, but people could freak out. Lewy body disease, hallucinations, the balance difficulties from mild Parkinsonism, you've got to be prepared for that. What are we going to do? Let's get that bedroom down on the first floor. Let's get those stairs out of the picture. So a lot of what you're going to do as a caregiver is understanding what might come next, right? There's 2 ways to caregive, I always say. You can do it reactively, or you can do it proactively. And for me, I will tell you, and for patients, the proactive approach, the being prepared, it's not just the Boy Scout motto, who now are changing their name to just the Scouts. I heard on the news yesterday or the day before anyway. Because when you're reacting, it's always disruptive. It's disruptive to you, and it's especially disruptive to our loved ones with dementia. So, again, just understanding that course is important.
Thank you.
I have a question.
Sure.
And I apologize, I had to be in and out because I was helping take care of my husband. When you were looking at causes, I never heard or saw anything about diabetes, but now they're calling diabetes the 3rd type of dementia.
Yeah.
What correlation have you seen?
Well, there are strong links of diabetes to both Alzheimer's as well as vascular dementia. And the field is still trying to figure all of that out. But it's clear, and I showed you that FDG PET scan, that radioactive sugar that the Alzheimer brain cannot use the sugar well. This, in some respects, is where that thought process comes from. And so we are exploring some of the new diabetes medications in some of our clinical trials for will they help slow down the Alzheimer process by allowing nerve cells to better use sugar and stay healthier. So there's a lot of work that still has to be done. With that being said, the majority of folks with diabetes, if their diabetes is well controlled, are at no greater risk for Alzheimer's disease than people without diabetes. It's people with diabetes out of control that are going to run into trouble with strokes and trouble with an increased risk for Alzheimer's. Same with blood pressure. High blood pressure is a risk for dementia, Alzheimer's as well as vascular dementia. But if your blood pressure is well controlled, it's no longer a risk. So I will say years ago, I went to see the doctor and found that my blood pressure was, and they took my blood pressure and they said, your blood pressure is 170 over 98. And I was like, no, I'm a teenager. 120 over 60. And they were like, all right, we'll check it later. And they checked it later. 170 over 98. So I called for an appointment. Immediately, I was at urgent care. I called my doctor and said, I need to see you at 7 a.m. tomorrow morning. And I stormed that, and I said, I want 120 over 60. She said, well, let's start with a low dose of a medicine. I said, no, big dose. Get me normal fast. And she wouldn't do it. She started me slowly, called me in a way, she said, I'll call you in a week and see how you're doing. She said, where's your blood pressure now? I said, 150 over 90. Give me more. She said, no, I'll give you a little bit more. Call me in a week. Where's it now? 140 over 85. Now, would you give me everything I asked for in the first place? And now, you know what my blood pressure is this morning?
120 over 60.
118 over 60. Yeah, baby, teenager. So I always say, if you want to know what you should be doing to lower your risk, do what I'm doing. Take care of those issues. No diabetes, no high blood pressure. Get those under control. Any other last questions before you guys move into a break?
I know you said the diet wasn't fully researched, but there's a lot of folks out there claiming brain healthy diets.
Yeah.
Any truth to that, or any
So,
specific?
yeah, we think so. We just don't have real good data from rigorous clinical trials. Why? Because everybody lies, right? So, right, you remember, I don't know if you're probably not old enough, but there was an old song in the 1970s, Junk Food Junkie. I don't know if anybody ever remembers that, but you put somebody on a diet where they're getting all healthy food, and at 2 a.m. they're out in the kitchen looking for the Twinkies. And of course, they're not going to report to the doctor, I ate a box of Twinkies last night. So they're hard to do, but we do know that a Mediterranean-style diet, and almost all of the diets are variations of that. The Mind diet is a variation of Mediterranean. And what that means is more vegetables and fruits, lower in red meats. It doesn't mean you can never have a steak on the grill. It means do that. So my wife likes me to only have red meat 1 day a week. Likes me to have fish 2 days a week. And likes me to eat vegetarian 1 day a week. which leaves me 2 days for chicken or whatever else is out there to try to keep me healthy anyway. So there's a lot that you can do diet-wise. As our patients develop dementia, though, you'll find that it's harder to find foods. Their taste will change, what they like. They will develop a sweet tooth. I usually say do not give them hard candies and chocolate bars. Give them fruit pie. Give them, right, like the old, well, can I have cake for breakfast? It's got eggs in it and milk, and give them a piece of cake, you know. Try to figure out what has components of a healthy diet in it that you can actually get them to enjoy. Ice cream, you know, don't buy the low-fat artificial stuff. Let's get some real ice cream, you know, that's good and healthy. Lots of protein, lots of calories. I'd be happy if my Alzheimer patients want ice cream for breakfast, lunch, and dinner. I'd give them a strawberry or something with some fruit in it for some additional nutrition anyway. So with that, I should probably end there. You guys enjoy the rest of your day. I'm glad that you're all here. It's a great way to get started with some core information that you'll build on over time. You have the hardest job of anyone in the world. And so preparing yourselves for that is going to make it a success for your loved ones and for you over time. So. Thanks.
Thank you very much.
Thank you.
I need to get my guests.
All right, we're gonna take a 5-minute break as we get switched out for the next presenter.
Hi again. I'm Meredith Flint. I work at the Alzheimer's Association. I'm running the Zoom back there, but not running it right now because I'm up here. And I'm just so thrilled that you all are here today. I'm pleased to introduce Diane Vance, one of our community educator volunteers at the Alzheimer's Association, and she's going to be doing a presentation about communicating with your loved one in different stages of the disease. So Diane, take it from here.
Thanks, Meredith. Well, good morning to everyone here and online. And I have to say that these workshops give you some great information, and I would have loved to have had this kind of thing when I was dealing with it. So I hope that you get a lot out of what's being said today. My background in this, my PhD is from UK. I actually worked with Sanders Brown Center on Aging. This was back when the dinosaurs were on the earth. It's been a long time. So I have a technical background in Alzheimer's and neurological disease. I didn't do that kind of work for my career. And I just kind of went on and I hoped I would never have to deal with it. 'Twas not to be. And so I do have some technical background, but I am really talking to you today from the perspective of a caregiver who's been there, done that. So I know a little bit about what you might be going through. This topic here, and you'll have to pardon my fiddling with the mouse, it's a little bit funky and it won't work with an auto changer, so be patient, please. This is about communicating effectively. It's not always obvious how we should communicate with people who have cognitive issues, and this is going to give us some ideas. I think that I'm going to shorten part of this. I'm going to leave out a couple of videos, and I think these are most useful. If you have comments, questions, suggestions as we go, please feel free, to suggest or give an example or something like that. I think that it can be one of the most useful things is interaction with each other. This is a whole series from the Alzheimer's Association. We are doing just one segment called Communicating Effectively. Dr. Jaika briefly touched on this, but we will expand a little bit more on that topic. I do not read slides to people. It makes me crazy.
Thank you.
And I see
Thank
other
you.
people agree. Here is what we hope to accomplish today. We want you to have some idea of how dementia might affect communication. and then describe some of the accepted ways that are most effective to communicate with a person who has some kind of dementia. In addition, it's going to mention a little bit some things about communicating with professionals, particularly with the medical professionals that you might be dealing with. This looks like an easy question. And in some ways it
Not in
is.
my house.
But we have to remember that there's more to communication than just what I'm doing now, which is being a talking head. So here's what communication is. We need to tell people what we need. We need to share our thoughts, feelings, ideas, and we use it as a way to connect. Fair enough. You didn't know you were going to have a test, did you? Hey, I'm an old college professor, got to do a test. Okay, multiple choice.
All of the above. All of the above.
And again, sorry, I'm not usually this uncoordinated. I don't think I have motor neuron disease, but I feel like it. This is important. We're going to see that, and you already know, you're here because you're caregivers already, I'm guessing. As people progress, their ability to communicate with you in the regular way of oral communication, back and forth, talk about this, that, and the other, really declines. But one thing I'm going to say more than once is, even though they might not be able to communicate with words, you're communicating. You're communicating with all of these other things. If you've been a teacher for a long time, and somebody's sitting there in my class, and they are, is this communication? Oh yeah, this is better than any words they might want to say. They're communicating. If your loved one has asked you the same question 5 times and you finally say, "You've asked me that question 5 times, stop it."
That's my house.
That was my house too. I'm speaking from experience here. I mean, even knowing that I was doing this on purpose, when I slammed the desk and raised my voice, did it not have, it has an effect on you. Don't believe that it doesn't have an effect on them. And I'm going to pick up on something Dr. Jaika says too, only I'm going to ask it in a different way. Is anybody here a saint?
Yeah, now.
We got one. And I asked that question because this is only one example of the many ways where you lose patients. And this is not what we should do, and we all know that. But we can't continue to kick ourselves because we're human beings, as Dr. Jaika said. So we do the very best we can, and we just need to try to also be more conscious of it. You saw the pictures of the brains of Alzheimer people. They're not trying to be a pain in the neck. They're not doing this on purpose to annoy you. Their brains are dying. And I think when we can see a physical handicap, if someone were in that chair over there and they were a double amputee, and I said, "Oh, for God's sake, go get me a cup of coffee. What is wrong with you?" Would that not be cruel?
Right.
But sometimes when people have cognitive issues, we say things akin to that, and we don't think about how cruel that is. So keep that in mind through all of this talk about communication. You've already seen pictures of this, and Dr. Jaika has talked about it. Often, communication changes can be some of the early signs. I'm going to mention some of the early signs with some of the other dementias that Dr. Jaika talked with you about. These primarily apply to Alzheimer's in the early stages. As things go on, as you saw, all of the dementias will eventually express all of these things. Now, has anybody ever lost their train of thought? No. I know, none of you have. I do, but I know none of you have. He's already talked about, what's that person's name who was in that movie? And then 2 a.m. Yeah, I know who that was.
Yeah.
You know, some of this is normal aging. We're talking here about long-term things, more severe cases, and something that is very different than what was before. Someone who was always very articulate and a good speaker and all that, it's going to be more noticeable for them than for someone who was not, you know, such an articulate speaker. Have you heard this term before? If not person-centered care or person-centered communication, it's not intuitively obvious totally, but when you see the definition, I think you'll look at it and say, yeah, when we care for a person, we should care for that person. And if you are the family member or a friend, you know them well enough that you can adapt to what you know they would like and need and what works for them. We all know what works for one person will not necessarily work for another. If you're a long-distance caregiver and you're dealing with someone who has hearing problems, and you say, well, I'm just going to call them every day and talk to them. Well, maybe. But if they're having hearing problems and they're trying their best to talk to you on the phone, but they can't really understand what you're saying, do you think that that helps or hurts?
Hurts.
In the long run, it probably frustrates them more. Maybe phone is not the best way. Maybe if they can see your face, if you can FaceTime, and they can see your lips, you know, often that helps people understand. So communicate with them the way that's best for them. They're going to make 5 points here about person-centered approach to communication. The first one, treat them with respect and dignity. We've already talked about adjusting to their likes and dislikes. Call them by their name. The third one is a big one. If you go with your loved one to the doctor, have you ever had the experience that your loved one is sitting right there with you and you're sitting next to him and the doctor's talking to you and ignoring the person next to you who has the problem? That isn't what you want to do. I experienced that any number of times. Now, he could understand the early stages perfectly well what was going on. Talk to him. And we need to do that too. I gave a talk at a facility one time, and the staff manager said, I want you to talk to the staff and tell them, do not talk about a person who has dementia to their family member while the person's sitting right there and act like they're totally ignorant of what's going on. They're probably not. They know what you're talking about. Don't do that. The correction part, Miss Scientist here, right? Chemist. What did I do? I wish I had known all this stuff, because I would have been a better caregiver. What did I do when my husband said something wrong? Well, I corrected him all the time. He had Lewy body dementia. Anybody dealing with that they know of? One of the very common things that happens with Lewy body is hallucinations. What did I try to do when, and this is a real one, honestly, would you look at that? The neighbors are having sex in the tree again. sometimes you have to laugh. You really do. And you know, what do I try to do? Oh, come on, you know, I try to correct. That was not the right thing to do. What can you do? Yeah, give me a response to that one. What would you do? Or,
Let me see.
I like that. Let me see.
Good for them for enjoying it.
You want to try?
No, don't tempt them. Sorry about that one. You know, the general idea would be, one of the things Dr. Jica specifically mentioned in his communication segment was distraction. I had people suggest to me, oh, well, maybe we should give them some privacy and close the blinds. Or maybe we should, oh gosh, we were going to watch a TV show. And a person with some memory issues, they can be easily distracted. And that's one of the things they often tell you to do, first of all, when you're dealing with a difficult situation, is to try to distract. So if you're dealing with the hallucinations and delusions, correction doesn't really work. Delusions. Very common one for Lewy body is the spouse is having an affair. Very, very common. I don't understand why, but it seems to be the case. And there's no point in trying to reason with them. Respond to the emotion. What are they feeling if they think you're having an affair? Not just with one person, but with all the guys in the house. You know, there were no real guys in the house. He was seeing them all.
Betrayed.
He's afraid.
Yeah.
That's what I needed to respond to. Reassure, respond to the emotion that you see behind some of the delusions or hallucinations. That one, I think, is really important. Validating their feelings is a big one. We all want that. Have you ever talked to someone about a thing that you thought was a real problem, and all they say is, oh, you got this, no problem. Did I tell you what I was going to do next weekend? How does that make you feel? Dismissed?
No, I don't.
Yeah, and
Nobody.
they're going to feel that too. If they're afraid, respond to that. We've already mentioned this one about including them in conversations, but when you do, it can't be rapid fire. They are processing more slowly. They are responding more slowly. Does it try our patience? Sometimes, yes, it certainly does, but we have to do the best we can with that. Dr. Jica mentioned, I thought this was a really good way to say this, they will mirror your emotion and your state. So if you are agitated and angry, they're probably going to get spun up into a state that is more agitated and angry. If you can be calm and talk in a quiet voice, the likelihood is that that will help calm them down too. So I think that's also an important thing to remember. Acknowledge, validate. One thing I hear a lot is friends and family don't want to come and visit because they don't know what to say. Do you get that? People with dementia often become isolated because their friends and family say, well, you can't have a conversation with them. Why should I come and visit? It doesn't matter what you're talking about. If they don't understand what you're saying and you get the same question 5 times in a row and you answer it, and they think they visited their mom yesterday and it was a great visit, that's just fine. What they will know is someone is here to talk to me, who cares about me, and who is being nice to me. They'll respond to the emotion. So it doesn't matter what you're talking about. So if their friends come and they say, well, this conversation makes no sense, doesn't matter, be there. Be there for them.
May I ask a specific
Sure.
question to that question? Do you have any recommendations for how to communicate that to children and teenagers? So in my specific case, I have teenagers, try to work with them on adjusting to, interacting with my mother, right, who is in stage Alzheimer's. So do you have suggestions for how to manage the conversation you were just talking about no matter what you say, focus on the emotion for folk who aren't as able to grasp it as quickly maybe as those sitting here?
I haven't dealt with teenagers in a long, long time since I taught high school.
It's not fun.
But I would try, I suppose, at first, a very direct approach in the sense that they, to some extent, should be able to understand that Grandpa is a different person because he has a disease, and go from there. Does anybody else have specific?
Let me address that to a certain extent. I always try, we live in a rural area and we don't have a lot of company or anything ever. So we go out a lot and go out and eat with people and go to the clubs, social interaction things that we used to do, plus get together with our relatives. Now, if you would notice sitting there that my husband is not really connecting. Everybody else is talking, but he has a good time anyway.
Yeah.
He really enjoys that, and as far as he knows, he's interacting with everybody, even though he isn't really. It's just the social occasion that he is happiest in. So just go with it.
Okay.
And as long as the kids understand, as she said about, it's fine.
Yeah.
It's good.
Thanks.
It picks up on what Dr. Jika said about, are they still smiling?
Yeah.
And it will be harder for kids. I had to laugh one time. My husband was with one of his grandsons who was maybe 6 or 7. Lewy body also has a Parkinson component, as some of you may know. So he went to his grandson and he started talking to him a little bit, and he said, you know what? I got the shaky disease. And he did this with the grandson, and the grandson picks up on it. Because at that point, we're talking 6 or 7 years old. And would I necessarily have taken that approach? No, but for him, he was known as the crazy grandpa. Did it work, and was it fitting for that situation? Yeah, it was.
There are some resources on the Alzheimer's website if you want the Alzheimer's Association for videos to watch with teens and things like that.
Oh, thank you.
You're welcome.
Thank you.
And I would suggest just making it a game, which, we want to talk about the here and now, and that's not the best way to deal with a dementia patient. And so we would do, for instance, my aunt loved to collect wheat pennies. That was just, and so the kids had a great time finding wheat pennies, and they'd hide them. And we'd go on these scavenger hunts, and she just loved it. My aunt loved doing that. I mean, you've seen, people who have danced in the past, we, just like you're saying, being silly or just enjoying life, it doesn't have to be, oh, my grandfather's sick and can't, it's like she's got 60 years of memories before this ever hit her. So let's find those. Let's do the scavenger hunt and find them. And I think teens, when we did it, to compare it to somebody at school that has, like you said, a physical disability or something, you have to work a certain way in order to know how to communicate. But teens want to. They may say they don't, but they do, and they'll get into a game of finding, how can I get here and how can we have a good time with someone living with dementia.
And I think that's a wonderful example of person-centered care. They knew what she liked and responded to that, so that's a great example. believe we've talked about this one. We do the best we can to be patient. Unless they have told you they want you to complete their sentences, try not to do it. Try to let them get through with what they're saying. And that the fourth one down there, give them choices, but don't get carried away. Because you give them too many choices and it's bewildering. So be a little careful about that when you don't want to just do an open-ended question of what would you like for supper. That's too much. And again, we have to be in the moment, not anything else. This one I think is probably pretty obvious. They have a hard time with one thing going on. You put them in a noisy environment or one that has a lot going on. Dr. Jaika, again, mentioned Christmas time. You got 25 family members and everything's going on. That's going to be very bewildering for a person with cognitive issues. And this one we've also mentioned. Nonverbal is so important. Long after they understand any of your words, they're going to know what you're feeling and thinking by the way you express yourself with your body language. Making eye contact is really important. One suggestion they make is if, for example, in a teaching situation, this is what I want. I'm up here and you're down there. And yeah, let's don't forget that. But when you're talking with a person, you might want to sit down and get on eye level with them. That can help a whole lot with the communication part. And I'm going to skip these videos in the interest of time here. You can have another test question. So you know how these tests go. You read a little segment and then you have to answer a multiple choice question about it. So here we go. Two best tips would be?
Hold her hand.
Definitely touch.
Read a book.
And read to her. And let's see if we're right. Yep. Everybody gets an A. That's the way school goes now, right? Everybody gets an A. Think of other ways to communicate. Reading is certainly a good one. And a couple points here about other people. This picks up on the question you had about how to talk to the teenagers about it, how to talk to other family members about it. I didn't do this enough, and I bet a lot of us don't because we try to carry on the best we can on our own. But other family members need to know as much as possible about what's going on so that they can adapt better to it. And so that they don't abandon that person who has the cognitive issues. Is this easy? No. They're difficult conversations because they very often involve future planning and what might happen, but they're important conversations to have. For going to the doctor, I always suggest take notes on what's going on and what you are seeing and what's happening, and have those at the doctor's appointment with you. You saw from what Dr. Jaika said that behaviors can tell you a lot about the different kinds of dementias. So in the early stages particularly, you don't see the same thing with Alzheimer's and Lewy body and frontotemporal. The symptoms are different. And the more you can let your doctor know about that, the better it is for him. You can also certainly take notes while you're there, and hopefully your loved one will let you go in with them. Sometimes in the early stages, they're a little bit resistant, but I bet
Well, my husband is completely resistant to any kind of intervention. And I'm very gentle. For example, we drove to Louisville with an appointment for Dr. Cooper that was no appointment was made. But my husband was certain he had an appointment. So then he resists. There's just enough ego left that he can do it. So what I'm having to do, and I feel just awful about this, when he takes a nap, which is happening more and more, I grab his phone and I go in and I see what we've got coming up, and I call those doctors and I confirm, because he cannot get it right now.
Yep.
He just can't.
I can't either.
Mm-mm.
Yeah, we have to adapt.
Yeah.
And this brings up another little point about, we were all told when we were younger that we shouldn't lie and we shouldn't deceive and we shouldn't be
It's
sneaky.
horrible.
Guess what? We have a new set of rules to play by now. And I've seen it referred to before as compassionate deception. It is difficult to deal with the resistance, and sometimes compassionate deception is the way to go. I don't want to take a bath. Well, but don't you remember your daughter's coming this afternoon, and wouldn't you want, the daughter may not be coming, they will forget about it. But sometimes you do what you have to do as gently as possible, as you say. And I'm going to do a quick thing here. You've already mentioned the Alzheimer's Association has so much information on their website. If you haven't looked at that, it's worth a look. There's a lot locally in the way of presentations, but so much on their website. If you don't know, okay, get coordinated. If you don't know about the 24/7 helpline, I think that's a big one. Staffed with not medical professionals so much as social workers, but honestly, at 2 o'clock in the morning, when you haven't slept for days, and he's standing there saying, "Why can't I just pee on the wall?" And you just want to talk to somebody, and sometimes they can talk you down off the cliff, so to speak. So that's a wonderful service that the association offers. We have local groups, and if you talk to Meredith later, she can give you plenty of information about local support groups and about the programs that they offer. And just in general, lots of educational programs. And I'm going to quit there so we can have a little bit more of a break this time. Yeah.
What is your last name?
Vance, V-A-N-C-E. Questions or comments? If anybody has any questions or comments, and again, I kid about this a lot, but my grandmother always said, "Well, yeah, but you're not a real doctor like your brother." Because he was a medical doctor. So I can't answer, medical doctor questions. Can I answer caregiver questions with an informed background? Yes, I can certainly do that, and would be glad to do so today.
We're having a lot of issues. We've been married 22 years, married late in life, and he was the most gentle, kind, quiet person. Now he is agitated, angry, very combative. So I am just at a loss sometimes. I mean, I do the best I can, but there are times when I go, what happened? And I don't know how to manage me so that I can help him. And if anybody in the room has ideas, I'd love to hear it, because what happens is that then I flare, and that is a very wrong thing to do. I know it is.
Dr. Jica referred to BPSD, behavioral psychological symptoms of depression.
Yeah.
These are the things that are hardest, I think, on the caregivers.
Yeah.
What you're describing is not unusual. They always suggest try behavioral interventions first before you try any drug interventions, which of course, you know, your physician could make recommendations possibly. There's no good answer for that because everyone is so different. What someone else might suggest some things and it works great for their husband. And you might try that with your husband
Yeah, not so good.
and not so great. So
Yeah.
I wish I had answers to these questions for you.
Okay.
And I
Maybe
don't.
she.
I have a little question. Where do you get those cards? My husband has frontal temp, and his
Oh, wow.
behavior, combativeness, now not with me, but in the car. He doesn't drive. I'm driving, and he has big fits. And the people, you know, that cow is going to hit you.
Yeah.
And sometimes they see it, sometimes they don't. So I was wondering if you, where those little cards might be.
Two responses to that. Are you familiar with the Online Association for Frontotemporal Degeneration, AFTD? They might have something specific for FTD, but I see Meredith in the back.
We have some in our office, and Regina has some.
I have some that I'll pass
So
out.
she's got some right there.
Hand them out.
Hot cards. We can answer a question, hot dog.
Oh, thank you.
Got all the cards.
Ask and you shall receive sometime.
Thank you. Yeah, I was going to say that.
Did you have a question?
When he was talking about to react when somebody's
you.
combative and hostile and different than what they've been before, I've encountered that as well. And the hard thing is to remember it's not the person.
Right.
It's a disease. And that's hard because I still
Yeah.
react as much as I hate to. You know, I've often said if she would just get worse, we'd get along better. Right? What a horrible thing to think.
Yeah.
But it's like when she doesn't know, when she quits arguing with me, it'll be fine. But right now, I'm like, redirect. If you can get them to do something else as you walk away, as you say, you know what, give me a minute, I gotta go do this.
Yeah.
Just get out of there for just a few minutes. Compose yourself, remind yourself it's a disease. You know, it's not him. Down there, all those 20 years together, that's what you want to remember. And then go back and do it.
And
And I-
go ahead.
Quick comment, and then I think we have to stop. Okay, one more, please.
Oh, I was just going to add to that. Like, I think another piece, and this is the hardest thing in the world to do. I acknowledged that at the beginning. But what you really have to do is drop your emotionality and your response to be
Yeah.
as calm and as neutral as you can.
Yeah.
Because part of what's happening is when they're in that fear, frustration, and agitated state, they are so flooded with emotion, right? That if you do what feels like what you so much want to do, right? Which is ramp up. That just creates a spiral. And so you really have to just like very consciously get as calm as you possibly can and respond to it like that. And then I think sometimes you have to leave the situation for a few minutes, like as long as he's going to be safe in whatever way he's in for 10 minutes,
Yeah.
walking away. Yeah.
One other quick comment.
I think maybe the first lady might need some outside help to come in and give you a break.
Yes. We're almost at that point. In fact, we probably are there.
You know,
And
might
I-
not help him, but it'll help you.
Right.
Help him.
Right. Yeah. Of course, that's hard
Oh, yeah.
because I think I've got it, but I don't have it anymore. I don't have it.
And
It's
it happens
beyond
to
me.
us all.
Yeah.
Understand.
Yeah.
Sarah, you want to
Thank you.
tell them about break time? Thank you for your
We'll take a
attention and for
very-
attending.
Thank you, Diane. What we're gonna do is our next speaker.
Alright, so as I said before, we're gonna shift gears to talk a little bit more about resources. So this is Regina Goodman. She holds many roles at Bluegrass Area Agency on Aging and Independent Living. I always refer to it as AAA, not the car place. But so she's here to share with you guys about some resources and about some of the programs that she runs that could be helpful to you.
All right, thank you so much, and thank you all for being here. We like to tell our caregivers the number one part of being a caregiver is taking care of yourself. And I know that sounds a little crazy, you know, I'm taking care of my loved one, but in order to be the best caregiver that you can be, you also have to take care of yourself. And I think being here today, learning about the disease, learning about some of the behaviors and things like that is one way of doing that. And also learning about the resources in your area that can help you with this journey. And so like she said, we are I'm with the Bluegrass Area Agency on Aging and Independent Living, which is a mouthful. I've been there for 13 years and still get tongue-tied saying it. But we are housed, our actual building is over on 699 Perimeter Drive, and we're housed in the Bluegrass Area Development District building, and we are just one of the programs under that branch. But I won't spend a whole lot of time on this, but if you talk to any of us, you will know that we talk in acronyms. And so when you call our agency and we're telling you about programs, we'll throw a lot of acronyms out. And so the Kentucky Department of Aging and Independent Living, we refer to as DAIL. The Bluegrass AD, as I just mentioned, the Bluegrass Area Development District. There's no easy way to say BGAAAIL, so there's no easy way to say it. And then our ADRC is our Aging and Disability Resource Center. That we will talk about that a little bit more later in the presentation. And then the Older Americans Act, OAA, is where a lot of our funding comes from. So
Has your funding been impacted lately?
I'm sorry?
Has your funding been impacted?
Not yet, no, we're just doing business as usual.
Okay.
Yes, and so every community in America is served by an area agency on aging, and in fact, our Bluegrass region serves 17 counties, so it serves Fayette and then 16 surrounding counties. But if you are here from a different region or online from a different region and need the information, like I said, there's 15 of these across the state, so we can help you find the information for your region if that is not here. So we're just gonna, so this is our area. These are the counties that we cover, and like I said, if this is not yours, then let us know and we'll get you to the people that serve your area. So these are some of our services: the Aging and Disability Resource Center, Senior Centers, Nutrition Program, Home Care, Nursing Home Ombudsman, Legal Services, SHIP, National Family Caregiver, Medicaid Waiver, Kentucky Caregiver, Bluegrass Mental Health and Aging Coalition, and Elder Abuse Prevention. These are just some of the services that we provide. We do not provide direct care in our agency, but we can refer you to those programs. So let's see. So like I said, we are the centralized intake for our programs as the Aging and Disability Resource Center, ADRC as we call it. So any program that you hear about today that you think you might want to be a part of, you can call me. I'll have my information at the end, and I can answer your direct questions about any of our caregiver programs. But in order to get actually enrolled, you have to start with our Aging and Disability Resource Center, and that's the number 1-866-665-7921, or you can email them. And so what we tell people is that once you call that number, you're going to leave your contact information. You more than likely won't talk to somebody. You may, but they'll take your information as well. But if you don't, leave a detailed message as to why you're calling, your contact information, and allow it a few days, even a couple weeks, for someone to return your call. They receive high volumes of calls. That is, like I said, that's the starting point. So everybody is calling that number, and so leave a detailed message. And it's not necessary once you've left that to keep calling back, like, oh, they haven't called me back, it's been 2 days, call them back again. That's not necessary. They will call you back in the order that they were received. Now, if you happen to miss their call, they will leave a detailed message on, who to call and what number and who to speak with and everything. So just make sure that your voicemail is able to receive those messages. And also, once you know you're receiving that call, answer your phone just in case it's them, even if you don't recognize the number, especially for until you contact them. And then you can go back to ignoring those calls. But until you're waiting for that call, be sure and answer your phone. And so these are some, like I said, some of the other programs. I'm not going to touch on those as much as I am, but these are available and more information. We're going to talk more about the caregiver specific programs, which is our National Family Caregiver Support Program. This is federally funded through the Older Americans Act, and our fiscal year goes from July 1st to June 30th. So we are on the back half of our fiscal year, but there is still time to access our funding. And so, so you call ADRC, you'll get screened for services, and then you'll receive our application in the mail. And then once you are approved, you can receive $2,100 per fiscal year. And like I said, it's already almost March. You still have access to that full $2,100 for respite care. And there's two different ways that you can utilize that through this program. You can either choose someone that you know and trust to stay with your loved one. And this is to give you those breaks that we were talking about, those periods of time where someone else can come in and stay with your loved one while you get a break. And that can look different for everybody. You know, that can mean just so that you can go to your own doctor's appointments. That can be you're going to take time to have lunch with a friend. That could be you just want to sit on the front porch and have a glass of tea and not have to worry about your loved one. And so it can look very differently, but you can either, like I said, hire the person that you know and trust to provide that, and we will reimburse you for that. So there is a little, out-of-pocket expense depending on what you pay them, and then a little bit of paperwork. And our paperwork has to be in by the 3rd of the following month after you use it, just to allow for that processing time. And so you can do that, or you can choose the agency that we contract with. And currently that is Independence Assistance of the Bluegrass. And so with Independence Assistance, once you're approved, you will do all your scheduling through them. They'll send their trained care assistant out to provide that respite, and then send us the bill. So there's no out-of-pocket expense for that respite and no additional paperwork. So the choice is yours, but those are just two ways that you can access that. And then we have $500 a year for supplemental supplies and services. And like Dr. Jacob mentioned, the incontinence supplies are so expensive. With this program, you can use that $500 to purchase diapers, wipes, chucks, gloves. Sometimes insurances will only cover like the adult diapers themselves and not all those other products that go with that. But with this, it does. And again, you can either choose to be reimbursed for that, or you can go through either Grogan's or Professional Medical Fulfillment to order those supplies, and then they'll send them to you and send us the bill. So there's no, like I said, some people, if there's a certain brand that I only get this brand from this place, and if you want to do it that way, that's fine. You just have to keep up with the receipt and submit that monthly. And because this is through the Older Americans Act, there are no income guidelines. You just have to be caring for someone 60 years of age or older, or younger if they have that dementia diagnosis. See, I just blabbered on and covered all of that already. Another component that we have under the National Family Caregiver Support is we help grandparents who are raising their grandchildren. So if any of you are in that situation, sometimes we find that when people send in their application for the caregiver respite, they have to list their household members, and we see, oh, you're taking care of a grandchild too. And so then they can utilize our that service as well. And with the grandparent portion, we help grandparents or relatives, aunts or uncles who are raising children. They have to be living with them, and their biological parents cannot be. And so for that one, we help with purchasing clothing, personal hygiene, school supplies, things of that nature. And we do some fun shopping trips to Walmart. We go to Walmart, and the grandparent can shop, and then we meet them at the checkout and check them out, or they can choose our online option.
Is that program statewide too, or just?
So it is, but so we all 15 of us have these similar programs, but it may look different in every area agency. Like they may not, their their amount of their respite may be different, or their supplies, but we all have these programs, and sometimes it just depends on the resources in that area and availability and that kind of thing, but we all do have those programs. And this is the Kentucky Caregiver Program, which is also a program that helps grandparents who are raising their grandchildren, but it's state funded. So with this one, there are income guidelines. You have to present that with your application. The grandparent can be any age. They don't have, I don't know if I mentioned in the other one, the grandparent has to be 55 years of age or older. But with this one, there's not an age requirement, but they do. We do have to verify that income. But also with this one, you're going to get $500 per grandchild, where the other program is $500 total. So there's a little bit more, especially if you are raising multiples, there's more assistance as far as that goes. And then Medicaid waiver or participant directed. So this is the program that if your loved one meets nursing home level of care, they could possibly receive their services instead of receiving those services in the nursing home, they can receive them in their home. That is quite a process. Our ADRC, Aging and Disability Resource Center, can help you through that process as well, though. Okay. And this is our SHIP, our State Health Insurance Assistance Program. If you have any questions about that, you can call as well. And let's see. So this is our number for how to report elder abuse, APS hotline. And then through our programming as well, just under the Area Agency on Aging, are some of these health promotion evidence-based programs. All of these things are still funded through the Older Americans Act. Our home care program is also designed to keep our elderly loved ones in the home as long as possible. And of course, all of these in-home services are for as long as it is safe to do so. We all want to have our family members age in place for as long as they can and as long as it is as safe to do so. There's some more information about our home care services on our website. And then this is my direct number and email address if you have any specific questions for me. But I wanted to talk about a couple of different things that have been mentioned today. And one of them is there's lots of different initiatives in Lexington, especially trying to educate people more and more about dementia and the caregivers, having more resources for caregivers and things like that. So I don't remember what, I think it was right before COVID, Dementia Friendly Lexington was developed. And so Dementia Friendly Lexington is a committee of people in the area who are trying to do that, trying to educate businesses, restaurants, realtors, churches, everybody really, just trying to get the word out on how to better to communicate and better to deal with our population with dementia. And this is one of those cards. So the QR code here will take you to Dementia Friendly, and it will give you like all of the resources for that and the places that have been certified for that. But then on the back it says, please be patient. The person with me has dementia/Alzheimer's. Thank you for understanding. So this is one of those cards, like if you're going out to eat with your loved one and your loved one may be experiencing some behaviors, just excuse me, my throat's getting dry. Just slide this to your server or grocery store checkout person or things of that nature. So I have these. I have these here with me, and we can get those. Thank you. I'm talking too much. I'm talking too much. And so, thank you, Sarah. And I know that I rattle on and I talk real fast, and I'm giving you a lot of information. So for that reason, feel free to contact me personally, and I'll be glad to go over this, a little slower and a little more one-on-one. And then a few years ago, the state level developed the Office of Dementia Services. And so this is actually a new whole department that is aimed towards giving resources and education about people living with dementia and resources for caregivers. And so one of the things that is offered through this is the state applied for a grant a few years ago called Bridging the Gap. And just like all grants, they come to an end. So this grant will be ending June 30th. But through this grant, you can receive additional respite funds. So in addition to our national family, this is another resource for that. And this has $500 associated with it for assistive technology, rather than the other one is for continence supplies and things like that. This is for assistive technology, and that can look lots of different ways too. It just depends on the need of your person. Some people have used it to purchase companion animals for their loved one, used it to purchase motion lights that come on to light up your hallway, so when your person gets up in the middle of the night and things like that. One of the things that people have used these funds for is for our people that may wander. You can buy the air tags and put them in their shoe, and so that way you can kind of tell and track where they are. But anyway, so this is the Dementia Care Services. Office of Dementia Care Services is the office, but if you have any questions, you can call me directly in this area. There are 3 dementia care specialists through this Office of Dementia Services currently in the state, us, Penny Ryle, and Buffalo Trace. But we'll be glad to help, anybody in any region. I'm actually conducting a Dealing with Dementia class in the KIPTA area in March, and that's a class, that's a class that I hope to offer here in April, and that will probably be at our office. I'm sorry for my voice, and I know I rushed through a lot of that, but does anybody have any questions?
Do you want to mention Smart 911 to them?
Smart 911? I don't have a lot of knowledge about that.
City of Lexington. So Lexington has what's called Smart 911, and it's localized here to Lexington. But you can go online and look it up, and you can kind of register your phone number and give instructions to the operator. So when that number comes up, it can also come up and say this household has someone with dementia, so that units can already be prepared as they're entering whatever situation comes up. They can kind of have some pre-knowledge of what they're going into. So it's kind of a nice feature to have, especially if somebody's wandering or something and somewhere you're going to be in contact with emergency services possibility. It kind of helps just give a heads up and help them when they show up be prepared on how to interact.
Absolutely, yes.
That can be very useful. There have been some very unhappy situations with people with dementia, and first responders don't know.
Right.
And you can also put anything in there that you'd want a first responder to know about. I have a pet in the house. I have a person in a wheelchair, even if it's not cognitive. Anything you'd want a first responder to know.
Okay, well, like I said, if you have any direct questions, you please contact me. I'll be glad to talk to you one-on-one, but I'm going to turn it over to Sarah. And I will leave these cards up here for anyone to. I think the flyer, the dementia service flyer, is in your packet, in your folder.
And it will get emailed out again later.
Yes, perfect.
Alright, so we're going to talk about safety awareness, which is our ability to plan, predict, and respond to safety issues. And what we realize when we're dealing with someone who has a cognitive disability of some kind, they may not be aware what they're doing is unsafe. They lose that judgment to know this isn't a safe practice to do. So their safety awareness is going down, which means then as a care partner, your safety awareness has to go up. So we're going to kind of just talk through some situations fairly quickly to kind of help you have those things on your radar and preparing. Kind of all of these talks we've talked about, I think, kind of culminate, and you'll see how they kind of intertwine
the goal is to help get you more prepared. So when it's about home safety, you want to evaluate the environment. So there are a lot of great resources out there. The Alzheimer's Association has one. NIH, National Institute on Health, has one online for home safety checks. And their sheets, some of them are 1 or 2 pages, some are like 5 or 6 that go into very big detail about each room of the house. And kind of go through and see, how is my lighting? How are stairs? Are there lights at the top and the bottom of the stairs? Handrails, talking about equipment in garages and things like that. And so those are really helpful tools to kind of go through and kind of see where you're at, what needs to change, what doesn't need to change. Sometimes it's helpful to have another set of eyes. So having a child come in or a friend come in who isn't quite as familiar with your house, that may see some of those things that you just don't see because you're used to it being there all the time. And then you're going to want to focus on adaptations. Dr. Jacka talked about you don't want to change a whole lot of things because that can be kind of a shock. But there are things where you can maybe do some simple little switches, like you talked about with the Christmas tree. So maybe instead of a large Christmas tree for the year, we go to a small one. So we make that change to make it more conducive for our loved one to be safe and at home. We also want to be realistic because there's a lot of factors to evaluate when you're looking at home safety. You know, if you're changing your home, what is that going to cost? Is that even realistic for you to tackle that? What is the time commitment to that? What is the turnaround time? If you have to want to regut your bathroom and do something different, how long is that going to take? Is that something that's worth it, or are there other options out there? And then knowing to reach out for help. That we've talked about this throughout. You need to develop a team, people who can help. Knowing about the resources and programs that are available out there to kind of help. And there are resources out there even for home safety. You can ask your physician to have a home safety evaluation that physical therapy or occupational therapy will come into the home, and they can kind of help look through each situation, the transitions for shower to bed, toilet, and kind of see how are you doing. They can tell you more about all the home safety equipment that's out there, and kind of help make sure you get the right set of material. We'll go through a couple of images, but there are so many options out there, and they're the experts, so it's always sometimes nice to kind of reach out to them. So dementia does have an impact on safety. It really affects our judgment, our sense of time and place, and some of our physical abilities. So we're just going to kind of run through how some of our physical abilities can affect safety. So when it comes to like taste and smell, we know smell can be a safety filter, right? If you put an oven or a cake in the oven and all of a sudden you start smelling something burn, you know to go check that. But if you can't really smell and you're still cooking, you may not have those same alerts. So it's always important to have things like smoke detectors that work. We also talked about some smell can affect our taste. And Dr. Jika talked about how your taste buds, as you progress, kind of aren't as good as they used to be. And so sometimes if you can't taste anything, you really don't know what necessarily you're putting in your mouth. So if there's a fake apple as decoration on a table, you pick it up, you take a bite, you may not realize that, and so that becomes a choking hazard. So it's important to kind of think through those things. Magnets that look like food are another really common thing that people see and then pop in. Talk about body odors too, because bathing becomes a big issue that we hear about with caregivers. And sometimes they don't realize they smell. They don't realize that their feet stink. And so kind of using that for you to know too as a caregiver, if you're popping into your home to check on your loved one and you start to notice that oh, maybe it's time we address bathing in some way. Simplifying the environment is key. So in this, we talk a lot about chemicals and food items. So a lot of times in kitchens, people will have food items, for cooking, but then they also have their cleaning supplies, their bleach or things like that. So making sure you keep those locked up so they can't be mixed up with something else. Same thing in the bathroom. A lot of times we also have other non-hygiene things in the bathroom. And I've got an example here later I'll show you, but kind of keeping in mind what that area is for, making sure it's simplified, easiest use, and then other things are locked up or put up in a different place so it's not as easy to get to. Always important if you can know the Heimlich maneuver or kind of have those instructions posted or having poison control number posted just in case you need it. Sight and sound. Dr. Jika talked a lot about processing, right? And Diane talked about this too, that our processing can slow down with time or with dementia as it progresses. Sometimes they even say that it can take up to like 90 seconds from when you hear something to when you like actually can process it and realize what is happening. But in that 90 seconds, a lot can happen. So being mindful of that, slowing down. But it's also not just processing that way, it's also sight. What do we see? What do we hear? And that 90 seconds can take place too. Our perception of images can change, and I've got some examples here I'll show you as well. So how I interpret the world can look different. The shadows, the way images come in through the window, reflections can all become an issue. A lot of times we see people who see the image in the mirror of themselves or somebody else, and it can be very unsettling. So it's learning how to adapt the room, either cover the mirror up or reposition things so that it's not as unsettling. So that's kind of being aware of the environment. Also talking about noise. Dr. Jacka talked about this, communication and things. If there's a lot of noise, if there's a lot of action, children running around, it can be overwhelming, and then you kind of just shut down. There are different safety measures you can use. We talked about smoke alarms. Sometimes smoke alarms can have both the auditory and the visual lights, which can be helpful because it's two different sensory inputs that are alerting there's something wrong. Emergency services, we talked about Smart 911. There's so many new technological features that can happen. You can have watches that detect falls. You have cameras that can help alert things, Alexa or other programs like that where you can kind of shout out, please call, and it can kind of help. And those can be very helpful if you as a caregiver are knowledgeable about them and they're not startling for your loved ones. Sometimes Alexa can be startling if a voice just pops up and starts talking to you. So you've got to check that out and be mindful of that as well. When it comes to visual, and I've got some examples here in a minute, sometimes contrast is really important because our depth perception can change. And so making sure we have clear contrast to objects can be really helpful. So here are some of the examples. So up there where the tile and those black spaces, sometimes the perception can be that those are holes. So when we're on a floor and we're starting to walk and all of a sudden there's hesitation because I don't want to walk because I think the floor is not safe, it might fall through, or maybe it's like a rope and I'm not really sure I want to go onto that. So being mindful of your environment and the flooring type. And sometimes it's even like this floor where there's a dark to a light, it can look like a hole and not wanting to step off of that. Sometimes that can be used to your advantage. When people are trying to wander and leave the house, sometimes a black rug in front can be a deterrent from exiting the house. So being mindful of, I talked about reflections, so it's kind of a picture of where does the window start, where does it stop? So kind of being mindful of that. A contrast kind of here with the commode. Sometimes we hear about people, they go into the bathroom, but they're not really sure what to do because everything is white. So it's hard to know exactly where the toilet is, where the bathtub is. So sometimes having a contrast, either with the paint of the wall, but sometimes you can even get those sticky, like non-slip things for a bathtub, and you can either put it on the bathtub floor or even on the bathtub wall to help make some contrast, and that can be helpful. And then this picture with the stairs. When I saw it, I thought this isn't a safety issue to talk about because it can be very hard to tell where the stair starts and where it stops. And so making sure you can mark those stairs clearly because sometimes carpet can be very deceiving and make it really hard to see, especially if the stairs aren't lit well, or again, you're having that trouble with depth perception. It's hard to really know. So just kind of being mindful of that.
From here, it looks like a slide.
Another big thing is judgment and decision making. Dr. Jacka talked about this a little bit. Equipment, kitchen appliances when you get something that's new. One of the big ones that we talk a lot about with safety are garbage disposals. Because if you're not thinking, what does this switch do? Because it's not connected to that device. If you happen to have something in the disposal or a hand or something and you're clicking, it can be really dangerous. So some of those things, it might be worth just unplugging and not using for a time. Depending on where your loved one's at in the progression. Power tools is another big one. Not saying you have to stop power tools altogether, but being mindful that there may be at some point your loved one struggles with judgment calls on where to put things and how to put things, so having supervision that you bring in for a while can be really helpful. When it comes to finances and scams, scams are really big. They're really big for everybody. But if you have a cognitive impairment, that can also easy prey, that can be a big target, and we see that a lot, unfortunately. So being mindful and planning ahead, making sure you've got power of attorneys in place, that you've talked to financial institutions, sometimes setting limits on bank accounts so that only so much can be spent, so limit the possibility of a scam. And then just monitoring finances altogether. If your loved one's been the one doing the finances all the time, and you know they've got a diagnosis, kind of monitoring. Are they still paying the bills on time? They are, great. Let them do it for as long as they can. But be aware of if they start to miss one, or if they pay a bill twice. We see that a lot of times. I forgot I paid it, so I pay it again or again, multiple times. Companies like that, but it's not so good on your monthly budget. So kind of being aware of those things. Medications are another big one. We love for people to be independent as long as possible, and we encourage that. We don't want you to take away things that they can do as long as they can do them. But this is another one that's really important for safety reasons, that it's done correctly. So sometimes medication planners can be really helpful, that they can go and check them. You can kind of see, did you take your morning medicine? Did you not? Sometimes people are able to do that, making sure they sit in a prominent place. They've got alarms set on their phone or reminders, and they can go for a very long time doing their own meds. But it's something, as a caregiver, you kind of have to keep monitoring to make sure that it's done correctly. There are places here, Wheelers does a medication management program where they deliver the meds once a week, individual little packets, morning med, PM meds. So there's different options out there if it becomes more challenging. Decisions is another thing we see where it becomes really hard to make a decision. So an example here is like the faucet. If I get in the shower and I don't know what is hot water, what is cold water. So sometimes it's as simple as identifying red and blue can help make those decisions for them. But being aware of that same thing along with scams, computers, what's an okay link to click, what is not an okay link to click, can be kind of just important information to be monitoring and watching for. Here's one of my examples. I talked to you earlier about kind of like chemicals in the bathroom and stuff like that. Toothpaste and like muscle rub, both in tubes, look very similar. Not going to do the same thing. So if the muscle rub gets on your toothbrush and you're brushing your teeth with it, it's not going to help your teeth. It's not going to taste well. So just being mindful of how things look, because a simple innocent mistake, you're grabbing a tube, it looks like a tube. That's what my toothpaste looks like. Can have some effects. Other things we talked about with appliances, sometimes as simple as a sign, a warning or a stop sign can help deter somebody. So if they can no longer really use the microwave well, they've been putting foil in it or utensils, just sticking a stop sign up there sometimes is enough to deter them. This is actually a doorway that has a sticker that's made to look like a bookcase. Yeah. So another way to deter a door that maybe you don't want them going down to the basement anymore or into a closet because they've been rummaging a lot. So just kind of a way to help deter. Physical abilities, we're really looking at fall and trying to avoid falls. So things we've talked about before, keeping your pathways clear of clutter, keeping the home well lit. We talked about stairs somewhat. Also being mindful of floors for liquids, easy slips, shoes, making sure shoes fit appropriately. Sometimes our feet change size as we age, and so making sure you've got good sturdy shoes so that's not a possibility of tripping. This is some of the safety adaptation, just some examples that are out there. That's where that home safety evaluation can be really helpful on knowing what's the best for a commode. Is it handrails? Is it a raised toilet seat? Do we need a transfer bench for the shower, or is there something different that we need? Because there are so many options out there. So it's good to know that there's options out there, but you want to make sure you get connected to the right kind. Sense of time and place. This is a big question that comes up. We kind of talked about wandering a little bit. Wandering is somewhat of a behavior that can happen. And wandering can happen for lots of different reasons. You can get disoriented and not realize where I'm at, or you might get back into old habits. You may be used to going to work every day because you've gone to work every day for 50 years. So you kind of drop back to that. So it's time for me to go to work. So I'm going to get up, I'm going to leave the house, I'm going to work. You haven't worked in 20 years. You're nowhere near where your job was, but you're not thinking that until you're out and you're wandering looking for a job where you're going. We hear a lot about I want to go home. So you go look for where your house is because you want to go home. So addressing kind of those things can be causes for wandering. So again, it's addressing that feeling of safety, security is a big thing. When it comes to wandering too, we've talked about eye tags, there's tiles that are available. If they carry their cell phone, you can do a Find Me. Google Maps, you can track people. So there's a lot of new technology that is helpful, but it's not foolproof. So a lot of times having ID bracelets or some type of identification on. I've had some families who their loved one still goes on a walk. He has a pretty well-known path, he does, but every day before he leaves, she puts a little card in his pocket that just has some basic information, who I am, my phone number, and she still kind of tracks him, but it gives him his independence to go walk. But she knows that he's got that information. If something were to happen, they'd be able to find him. And driving safety, we'll talk about that a little bit more. Driving's a big question that comes up because it's a loss of independence. You know, in this disease, you're starting to lose so many different things, and driving's a big one. So there's some questions that we ask to talk about. Are you starting to notice that your loved one's having trouble finding places? Or are they going out on errands that should normally take 20 minutes, but it's taking them 45 minutes? That might be a sign that they're taking a couple of wrong turns. They may still be able to get home right now, but it may be something to kind of pique your antennas to say, maybe there's something going on. Have you noticed in other areas that they're making slower decisions or poor decisions? Because we know our processing speed slows down with progression, and processing speed is really important when driving. You never know when a car's going to jut out in front of you, construction's going to happen, you have to completely do a new route. How are they when it comes to getting angry? Do they have all of a sudden a very short temper? Or when they're starting to get confused, when things get a little out of the norm, does confusion take over? Those are kind of things you want to think about. Do you want that behavior behind a wheel? And what would happen if they're behind a wheel and those things do happen? What does that look like and what does that mean? Also noticing if there's been an increase in fender benders, are there a couple more dents on the car than before? Or have there been more speeding tickets than before? Those are all signs that something's changed, maybe needs to be evaluated. And then if they self-limit, you know, you might notice all of a sudden, they're like, you take the keys and you drive today, I just don't feel like it, or I'm not feeling great. Them self-limiting might be a sign that they're not as comfortable, but they don't want to say, I don't want to drive. So those are all really important things to look into. We also encourage caregivers to get in the passenger side of the car, go on a ride with them, see what you think. Do you feel safe riding with them or not? When it comes to this decision, there are definitely scores that on the clinical side, if the doctors see their cognitive test, they're going to have that conversation. I don't think it's safe for you to drive anymore. Our doctors are very willing to write a prescription on a pad that says you cannot drive anymore. So you can also ask other doctors to do the same, so that when that conversation comes up again, remember the doctor said you can't drive. So it can be a visual thing. Make the doctors the bad guys. You don't have to be the bad guy. Because like I said, I know this is a really hard conversation. The Alzheimer's Association also has great resources online with some contracts of kind of helping talking points and how to have the conversation. There are also driving evaluations. University of Kentucky has a program. It is about $500, but it is where you go out with an occupational therapist. They drive the roads with you. They look, they do training afterwards, and they can be another independent voice that can make that call. And some people need that independent voice. And Regina, is it correct that caregiver programming money can be used for like the driving evaluation?
I have never been asked if it can be used for that. I look in for that.
Okay, that's what Kelly had said, so I just want to double check.
Yeah, that's nothing that we have done before, but that doesn't necessarily mean that we can't do it.
Okay.
We just have to.
Okay, so maybe a possibility. So overall, just reminders when it comes to home safety, checking devices, smoke alarms, carbon monoxide detectors. Also remembering to have a plan. So kind of we talked about trying to get you thinking ahead of time. Same thing comes when it comes to disasters or other things, kind of having a plan. What would happen if a tornado hits? What am I going to do? What happens if my health becomes where I can't take care of my loved one? What are kind of some plans in place? You may not have to do it all, but kind of having some thoughts ahead of time. I say, you make plan A, B, and C. You might end up needing D, E, and F. So kind of just thinking through what would that look like. Another big part is, can my loved one stay alone? That being able to leave your loved one home alone. We encourage you to think about a couple of questions. If a smoke detector were to go off, or if there's something smoking and flames, would they know fire, get out? Because that's a really important one. But also, what would they do if somebody came and knocked on the door and said, I'm here to fix your cable? Would they invite them in? Would they let them just come in and fix the cable? Or would they know, no, we don't have cable, or no, we didn't call anybody, and turn them away? So those are scenarios that we hope never happen, but you want to think about and protect your loved one, kind of have a good idea of what they would do. And at some point, it really is no longer safe for them to stay at home. And so that's where some of these other resources come into play. And then needing a break. We've talked about this over and over again. Taking care of yourself, making sure you find ways to express the emotions when you are angry or frustrated. It's really important that you have those releases too. So bringing in caregivers, adult day programs, things like that, so that you can get the break and your loved one can be cared for. I'm going to stop it here because we're kind of running out of time. A couple of just plugs that are things that Meredith and I do together with the Alzheimer Association. We do host a monthly memory cafe, which is just a social group where you and your loved one come together and we do fun activities. But it's a good place that you can come monthly and enjoy. Our goal is for you to laugh. The topic changes month to month. So some months you may really enjoy the topic, other months you may not come, and that's okay too. But it's just an activity that's out there geared for those with memory disorders and their loved one to come and have fun together. And so you've got a flyer in there about that. And I would be remiss if I didn't tell you guys, since we are here at Sanders Brown, that we do have ongoing research, clinical trials, and things that are happening, like Dr. Jacka talked about. So if you or your loved one are interested in what research opportunities are out there, I've got a form in the back that you can fill out, and one of our team members can reach out to you and kind of share some more about the different research projects that we have. Meredith's going to put that link online as well. No pressure, just want you to, if you have any interest and would like to know more information, we would love to share that with you. So I know that's a lot and a little bit of time, but does anybody have any questions?
Just to mention, I was a caregiver, but now I work for the Aging and Disability Resource Center. If you need adaptations to your home, there are some financial resources to help with that. So,
And there is the home safety sheet in your folder, does have a few of those resources listed
okay, great.
as well, but also calling the resource hotline, both the Alzheimer's Association or their Agency on Aging can help make those directions for those who live outside this area.
There are resources for home adaptations, things like that.
Yeah.
Just let us know what you need.
Yeah.
Also, another reminder, in Fayette County, the fire department will come out and replace your smoke alarms if they're over 10 years old for free.
Mm-hmm.
So if you're not sure, check them and all that, they'll come out there and just replace them.
Yeah.
Good service.
Well, we thank you guys so much for coming and giving up a morning to come and be here with us. We'll be hanging around if you have questions. Be looking for emails coming from me. It may take a couple of days for the video to get processed and everything, but I'll try to get at least handouts out today. As many PowerPoint slides as I can get. Sometimes Dr. Jacobs take a little bit longer for me to get. But I'll definitely get everything out to you as it comes to me. And then you'll have my email address. I'll make sure I'll have Regina and Meredith's email address there as well. So if you have questions, you can reach out to us as well. So we just appreciate you coming, and thank you so much.
Thank you.
Thank you.